Thank you very much for being with us today. We had this pre-panel discussion, and what's startling is that healthcare is a sector or a space that touches each one of us here in some form or the other. We've all been through our experiences, and we'll have plenty to share. So I intend to keep about 35 to 40 minutes of discussion here in the panel, and then throw it open to the audience for a quick question and answer session. We'll keep it interactive as much as you'd like to. Uh, just for a quick opening remark, we're doing away with opening remarks from each of our panelists. We'll go headlong into the discussion. And to set the stage, the theme is really innovation and how that can really improve customer experience, patient's experience, how can it bring down costs, increase the value being offered, what role can the government play, and where is this sector on the government's own radar? So these are the questions that we'll have to find answers to. I will first begin with Sangeeta right here. Innovation is this big theme that we're talking about, how it has the potential to change how healthcare is offered in the country. Why don't you talk to us about your own experience with innovation at Apollo to begin with, and then with the industry at large?
So, morning everyone, and this is a great opportunity to just share some insights. I think that at the very beginning, Apollo, 30 years ago when we started, we really believed that we were innovating on the model itself. So uh, we were the first multi-specialty so-called corporate hospital. So being listed on the stock exchange itself was a financial or funding innovation. But in terms of the management team, etc., nobody, even believed it. But we got a housekeeper from Taj, we got a materials manager from the TVS, from a factory system. We got a human resources person, also from a factory, and put these together and said we want the best of management techniques and processes to be applied in healthcare, because hospitals are in fact as complex, if not more complex, than most industries. So I think structurally thinking about a hospital ecosystem as an industry, as a service sector like a hotel, and as something that needs to generate an operating surplus so that you have something to put back in. These were, at the very beginning, some of our largest innovations. But this culture of bringing something new, whether it was an equipment or Six Sigma or Kaizen or quality circles, or now what we're doing in Aragonda, and then to move on to what we've done in telemedicine. So we started with telemedicine in rural India almost 10 years ago. Now we're, globally doing telemedicine. And then there's the internet, there's the web, there's mHealth. We'll be launching an app soon, which is a fairly comprehensive app. So I think it's a culture, it's multiple initiatives, and it's an acknowledgement that innovation is constant, and innovation is only meaningful if it's ultimately touching the customer and the individual. So I'll stop at that, because I think there's a lot that could be said, but there are a lot of smart people in the panel.
Oh, with that, let me throw this to Mr. Vijay, who's from Fortis. What is the scope of innovation in a sector like that? Multi-layered, multi-levels, the innovation can happen, but how much of the innovation is really going on as we speak?
There's plenty happening in pockets in the industry. I would say as the West moves from healthcare to total health, uh, we have long ways to go to deliver healthcare to the majority of the population. And the only way we are going to be able to do this successfully is if we use all our resources available in the health sector, but most importantly, look for disruptive innovation that can actually affect the masses. I'll just give an example of a case that we had at Fortis. There is an acute shortage of intensivists in the country, and we were finding it challenging to manage patients who were critically ill in our ICUs in remote locations. So we pioneered a concept with GE, which now has been followed elsewhere as well, but we were the first people in India and Asia at that time to come up with remote monitoring of ICU beds from a central command center, delivering the same level of critical care service as would have been possible with an intensivist at the location. So today we cover about 15 locations, over 250 beds, and have already saved so many lives monitoring this. These kinds of innovations are going to lead the way of being able to reach the masses. The other aspects that Sangeeta just mentioned in terms of e-health, we have a telecalling system in one of our sister companies where you can actually consult a physician online, and it's akin to what you have in Mexico, which is affecting almost 10 million people, at a marginal cost which is built through their mobile phones. So such kinds of innovation need to be encouraged across the system of healthcare where talent will remain a huge shortage. So I think we've made small beginnings as individual companies or groups. What we also need to start thinking through is that start working on common platforms across the country to affect the larger piece of the population, which we are missing today. So many examples within India and overseas that are available. And one, I would say, which is fairly critical, which not much attention has been paid yet, is the age-old adage of prevention is better than cure. So today, in the West, an example of a New York hospital that is monitoring their elderly patients at their homes are preventing almost 40% from coming to hospitals, otherwise who would have had to come for disease treatment. So we need to think through ways, although home care is evolving, how do we build a seamless system between the healthcare delivery provider, the home care provider, through innovation.
Thanks for that. Gautam, if I may throw this to you, in a sector like yours, is it, and this seems to be a more sector-specific issue, is the need for change driving innovation, or is innovation driving the need for change, like it happens in some other industries?
You know, this is a tough question because I don't know which comes first. But I have to say that the need for change has been there in the healthcare for a long, long time. So people have understood the need, they felt they wanted to do something. What is happening now is the culture of innovation, and what we heard in the earlier session of people trying to do new things and trying. So all the innovators are coming forward. There is an openness talking about doing something different. I mean, I've had people coming and showing me some solutions which 5 years ago I would have not even, I mean, they're very easy, but 5 years ago nobody would have thought about it, but now they're coming and talking about it. And the reason for that, and if I can take a minute on that, is when I thought about it, that what Ms. Sangeeta Reddy talked about, that's hospital is a complex organization. And also the other challenge in healthcare, it's very location specific, which Aditya talked about. So if you can get over this challenge of being location specific, and if you can do remote care, or you can somehow build scale, that will really drive the innovation. And an example I would just leave here for some thought here is many years ago, decades ago, when India started on the steel revolution. So we did have steel plants in remote areas, and those steel plants were factories, and they had people living, and they were good people, and the industries came up. So is there a way where we can think about having some kind of healthcare infrastructure, whether it is through aims like teaching hospitals or some overall healthcare campus kind of thing, where you provide where the professionals would also like to go and stay, because they get to learn and they get to do some research, and they can provide care to the people, and they are taken care of in their basic needs. So if there is a model like that, that I think may drive a lot of innovation in the country.
Dr. Mishra, can I throw this to you? Is a model like that possible at, say, a center like AIIMS?
Thank you very much, and good afternoon, ladies and gentlemen. Healthcare is at crossroads. I think all these speakers in the morning, and if I start with Dr. Didar Singh, Sangeeta ji, and Mr. Wadhwani highlighted the need for developing mechanism by which we focus on rural and remote areas of India. Urban areas have been oversupplied with these services, if I may say so, barring those who are economically backward. Now, if I look at the WHO projections for 2020-25 or 2030, what are the 3 top diseases which will be responsible for disability adjusted life years? One is on the top is cardiovascular diseases. Second is mental health illnesses. And third is injury, trauma. The burden of trauma, 88% of this burden is going to be in developing countries like India, China, Vietnam, Philippines, and whatever we talk about. And trauma is the disease which is largely preventable. I may not have any control on developing a cancer of prostate or lung or for any organ in my body. As a doctor also I can't predict, can't diagnose, but trauma is largely preventable. It consumes 3% of our GDP, whether we want it or not, whether we like it or not. No person in society is immune to this disease. It happens with the most modern cars. It happens with the person walking on the road as a pedestrian. And I was just talking to Mr. Wadhwani outside this room that 72% of those who are killed on our roads, we talk of tsunami, which hit the Indian coast in 2004. And whenever I talk about it, I ask people, how many people do you think were killed in tsunami when it hit Indian coast? Somebody would say 10,000, somebody would say 30,000 individuals. When Himalayan tsunami hit the Uttarakhand last June, June 2013, how many lives were lost, washed away? Maybe 10,000, maybe 30,000. What is happening on our roads is 150,000. These are the recorded deaths of young people who are breadwinners for their family. Now, if I have a heart disease, I may choose not to get treated. Maybe I'll die. If I have a cancer, I may not choose to get treated. I don't like chemotherapy. I said, no, I don't want. Let it happen, whatever happens to me. But when I have trauma, I cannot avoid. It pains. If I break my bone, if I break my back, it pains. I have to get it treated. The most common reason for rural indebtedness, and now it has become an urban indebtedness in India. It's not only rural any longer. The pre-hospital care, we all know it is developing, but it's still far. We don't have a system, trauma system as of today. Now, when Sangeeta ji says that 80% healthcare is provided by the private care providers, I say it's a incomplete description of the kind. Because that 80% is accessible to how many Indians? Then there is a significant segment is of health tourism coming from overseas. The 20% healthcare which is being provided by public funded institution through taxpayer money is competed by 80% population. And we have to think, industry has to think about it. And that's what Sangeeta ji very rightly said today. 70% of our healthcare equipment, instruments are imported. What are we making in India? CT scan might have been discovered 30 or 40 years ago, but still we do not make a CT scan in India. We do not make an MRI machine. We do not make an ultrasound machine in India. We are so much dependent on technology being imported, that's easy. These are low-hanging fruits. Because you import it, you sell it, you make profit, you are happy. But what have we done in the process? Similarly, how many molecules we have discovered in India which we are using in India, and also yet they are being used in USA, which were innovated by our pharma industry. Again, we are harping on generics, which are discovered outside, not in India. So I think we have to think from out of box. I was on the other day in the Scientific Advisory Committee of the Indian Council of Medical Research. The one point which was being discussed case after case was the industry is not interested in embracing these innovations, which may not be very attractive for profit making in the beginning. They may become profit making at the end, but to them it does not look like. They were saying particular plant extract reduces the complications of diabetes. Indian Council of Medical Research gave funds to investigate, research. It has been found out. Now, how do we take it to commercialization? And for this, there are many other of this kind. Another example, which just I was talking to Mr. Vadvani, 72% of automobiles on our roads who kill young lives are two-wheelers. Let's look at who is selling the largest two-wheelers in India. What have they done out of CSR to do a research where we can make a lightweight helmet which is airy and it is liked by users, and they put on that helmet and fasten it. Today when he is talking about ICU care, critical care, I don't know how many of you know that it costs somewhere between 50,000 Indian rupees to 100,000 Indian rupees a day, and how many of us can afford that? From our pocket if we have to pay, or even how many insurance companies will support that? So I think we have to see that if we can prevent these severe brain injuries in the first place, and everybody is talking prevention is better than cure, or prevention is much better, much cost effective in long run. So I think these are the areas where we have to work. I'll just close by briefly mentioning, I shared the podium with the health minister 3 times over last 2 days. One was the gynecologist conference on endoscopy. One was the cardiac anesthesiologist conference. Another one was Shri Ravi Shankar ji from Bangalore. And he had just returned from Missouri, where he visited a clinic where a couple, a physician and a pathologist wife, practicing for last 35 years. Dr. Saab would know, Dr. Lal Saab. And he said, the story what they told me, I had tears in my eyes. Then he went to a district hospital there. He asked the young gynecologist, beta, what are the problems? She says, sir, there is a lady walking into my clinic in the hospital. She is pregnant, but she doesn't know she is pregnant. She has hemoglobin of 5 grams. That is killing. 1.5 million children, they don't reach the age of 5 years. So what he was appealing to the professionals in all these 3 meetings, he didn't talk about endoscopy. He said, I am not going to talk about it. He didn't talk about the cardiac anesthesia. He said, I am appealing all of you, please, health tourism of different kind. I appeal and invite all of you to come, spend 1 week, 2 weeks, 3 weeks, whatever time you can spare. We do go on vacation on a hill station. I invite, please go to vacation to Missouri, to Uttarakhand, many areas in Uttarakhand. You serve, you do the sightseeing also, enjoy with family. Spend some hours, and I think that's a brilliant idea which I think we need to push forward. And I think FICCI also can contribute here, because this couple, what he was talking, they go Wednesday, Saturday, Sunday to villages in Uttarakhand. And they have been doing it for last 35 years without any recognition of the kind which people these days aspire immediately. And they were providing medicines from their own pocket. Then I think Birla Foundation or somebody recognized, and they started funding the medicine provision to their clinic, and through that to the patients. So I think the problems are in plenty. And what Mr. Vadvani, I liked his ideas. We may not be able to eradicate everything we are aiming at, but at least if we can begin in next 20-25 years, we can see some light at the end of the tunnel, where present-day government, like I think Shobha spoke about Ayush. What have we done with Ayush? Have we really investigated that it works or it doesn't work? We have not, except yoga or Sudarshan Kriya or Pranayam, what have we investigated? So I think these are the things which can prevent many diseases, and good part of India is the incidence of cancer is still much lower than Western countries. Any cancer you name, the commonest cancer in women, incidence in US is 150 per 100,000. In India, it is 30 per 100,000. And no cancer has higher incidence than this. All of them have lower incidence. So if we tackle these problems in a systematic manner, we can achieve a lot. Thank you very much.
That brings us to the point of cost, doesn't it? I mean, all of us have been to hospitals, paid huge bills for good or for bad reasons. I want to throw this to you, Divya. We were speaking about this initially. Innovation to reduce costs and increasing the overall customer experience. How much of a challenge is that? And what are hospitals like yourselves doing about it?
So I think innovation really needs to be on both fronts. It needs to be with existing institutions where we need to work to take our existing medical talent as well as infrastructure out there, whether it be through new telemedicine systems or smarter medical devices, so that we can take it out there to the rural and the semi-rural areas where it's actually needed. But I think apart from that, there's a lot we can also do within our existing institutions to make medical care more affordable. I know we were talking about this earlier on how medical care even in cities has become unaffordable for people. And for example, at our institution, we are working very closely with our medical teams to look at how can we reduce the cost to the customer and make medical care very affordable. So I think those are things that we need to bring in on a regular basis, and I think that's where the will is required from existing medical institutions to work on encouraging innovation within their facilities. Apart from that, I also feel it's important to have a system that encourages new startups to come up. Today the challenge is not only in who will fund these new innovative startups, but I think the second challenge is what is the payer model. If you see in the US or you see in Europe, you have a lot of these innovative models coming out because you have the insurance companies paying for it. So if you look at India as a country where the customer is largely paying out of pocket, it is very important to work jointly with the government as well as the industry and the insurance companies to work out who's going to pay for this. Is it going to be the customer? Is it going to be the government, non-profit institutions, insurance companies? Because I think till we focus on that and find a solution, it's going to be very difficult to encourage people to come up with business models that actually go out and reach to the customer. So I think we need to look at that part as well. Is apart from looking at existing institutions, is how do we look at funding for new institutions?
We'll come to government intervention because I think that's the next obvious question to ask. But I have a question to ask Mr. Iyer here. We were speaking about research, we were speaking about innovation. It takes so many years for that research to actually convert into cure. You're perhaps the best person on this panel to answer that question. Are we going to see that come down? Is that the biggest challenge the industry faces?
Hello, everyone. What I'll do, Supriya, if it's okay with you, I'll begin by touching on how a pharmaceutical company can innovatively collaborate with very diverse, stakeholders to really make a difference with access. I need to. Yeah.
Let's just keep our answers brief so that we have many more topics to cover.
Yeah. So I'll do it really, telegraphically. The example that I'm giving is not about publicizing what Abbott is doing, but it's really innovative collaborations to make a difference with access. We collaborating with the government of Puducherry, where we are, looking at every single adult over the age of 30 to, create awareness, prevention, diagnosis, treatment of 4 non-communicable diseases. We will also methodically create a registry which will show what are the prevalence. We are collaborating with an NGO called PATH, where our nutrition scientists from abroad are actually collaborating to fortify ultra rice with nutrients to make a difference with malnutrition. Collaboration with academia. We have an collaboration with IIM Ahmedabad, where we are really trying to find out how do we leverage technology to improve access. What we are really talking about. Providers. We just got into a pilot with Apollo Delhi, where we are now looking at nutrition protocols which can actually improve access. It can reduce the total cost of treatment, get the next patient in, so on and so forth. With diagnostics, we've tied up with ThyroCare, where we make access
to diagnostics easier, and we also subsidize it to make it more affordable. So I can go on and on. Coming to, R&D, that's, product innovation, of course, is at the heart of what a pharmaceutical company, stands for. I think the endeavor is how do we come out more than best in class with first in class, which can really make a difference, in here. And I think the challenge is how does one strike the right balance in developing economies on ensuring every patient has access to it, and at the same time, pharmaceutical companies get a fair remuneration for their investment in R&D and technology.
Fair point. Let's just turn focus of this discussion and really talk about process improvements, because I'm sure that's happening at most of the hospitals who are represented on this panel. Gautam, I'm going to begin with you, and Aditya, I have the same question for you, but you go first. I'll let Gautam go first on process improvements. We'll come to you next.
One of the challenges in a hospital is, of course, that all the the process improvement has to be on an ongoing basis. So all the methodologies of Six Sigma and all the quality TQMs and everything, they're all applicable there. So most of the hospitals, I think, are using those techniques. The trick, however, and what we've found is that the trick, however, is in keeping it on a sustainable basis. So many of these process improvements happen because somebody says you need to reduce the cost of so and so procedure, so which is done. But then on a sustainable basis, how do you ensure that the learnings of that process improvement are carried on? So that is a bit of a challenge which each hospital needs to internalize. The other thing about many aspects, and I'm including in process improvement not only the clinical guidelines, treatment guidelines, but also like how you run a large organization and help it to scale. So those improvements, I think most of the hospitals are now coming and doing that in the country. So that will work. But I just want to take a minute, and Supriya, if you give me a minute, I would just want to add one point to what Divya said. She talked about funding, and I was reading that government has been organizing many, announcing many schemes, and all of them are very good schemes. So I have no doubt about that. All of them very good schemes. But in my mind, I am little confused that if we want to provide access to people who have to walk 30 kilometers, 100 kilometers to the nearest public health center, so I am giving a scheme so that they can pay for it, but I have no physical infrastructure available there. So is it something that we need to think about, that the funding also has to go in improving and giving physical infrastructure, either through remote care or whatever? And one challenge which we heard in the last session was somebody said that they went to the doctor and the doctor was not there in the public health center, and so on and on. So just to think about it, that why do people go and work there? So people work either because of their livelihood or because of their charitable objectives or any other objectives. So I think those things have to be thought about to provide access to rural population of the country. We need to give professionals the opportunity which they would otherwise get in a city. Otherwise, everybody would migrate to the city. Sorry to digress from the process improvement, but I think that's important. Thanks.
Aditya, you want to take forward
Yeah,
that?
I had a couple of comments actually. I spent over 2 decades in the manufacturing industry. In the manufacturing industry, as all of us know, and I think Japanese termed it Kaizen, since we have many Japanese delegates, continuous improvement is in the DNA of everyone, whether it's at the plant floor, in management, in senior leadership, and so on and so forth. I think few efforts that we've made, for example, I mean, I'll use them as examples, is that we run a network of over 60 locations, and how do we thought through and said, how do we make it seamless for anybody coming to any location of ours? So we devised what we call the Fortis operating system, which is intuitive, where we studied almost 120 processes and came up with very detailed process steps. And honestly, as we improvise at individual facilities, we have a closed loop system where it comes back to the entire network again. Similarly, in the medical domain, we monitor certain aspects under the medical operating system. And that too is a common thread that runs across our facilities. So I think one of the things that we must all work on when we talk about innovation is how do you continuously innovate in your processes to be able to deliver consistent care with the highest outcomes as one would expect in the West. And I'm saying that we've seen efficiency levels on productivity levels go up multifold at many of our institutions, where waiting times, utilization of equipment, and so on and so forth have gone up 3 to 4-fold in many cases. So I guess I would say that process improvement, even in our domain, is a continuous game. And I think the journey started, and I'm sure that others are following it as well.
Sangeeta, I want to come to you on this. The whole consumer behavior angle to healthcare. You're not really dealing with corporates who are looking to boost bottom lines. You're not really dealing with, if you're a car manufacturer, you want to make the most stylish car. Here you're dealing with patients, critical healthcare is required, lives being threatened. What scope do you have for improvement, especially given the consumer behavior relevance to it?
There is undoubtedly tremendous scope for improvement simply because medicine itself is an art and a science. And medicine is a cumulative build-up of knowledge over years, and that knowledge translates into process or behavior patterns of doctors. Those behavior patterns get fine-tuned, evolve, stay static, depending on the individual doctor and his field or his expertise or his exposure. The ability to translate something as esoteric as medical quality into identifiable steps, and the universal thrust of healthcare is improve quality, reduce cost, enhance access. It's as simple as those three things across the parameter. So when you take the processes that have been perfected in, say, manufacturing, etc., and we call it Apollo Clinical Excellence, ACE at 25, we've tried to demystify to the degree possible, while not removing the empowering role of the doctor, into quantifiable steps. But a simple example that I think I credit not the Apollo cardiologists and the cardiac surgeons, but actually cardiac surgeons across India. India has the largest series or the largest number of doctors doing beating heart procedure. And a beating heart procedure is technically tougher than putting a patient on a pump. But the innovation is that first you save the oxygenator cost. Why did Indian surgeons get pushed into beating heart? Because they wanted to save 7,500 rupees for the patient for the oxygenator. So they took the extra trouble to do beating heart. Then, of course, ICU stay is less, the incision is less, the blood loss is less, so the patient gets better faster and ICU care is less. So when we can take the process innovation of Six Sigma and Kaizen and apply it into the medical field and make doctors your partners in care, which is what we're constantly working on at Apollo, that's when you get, if I remove one receptionist or improve the process, I put the lab tests go by computer, the lab samples go by the pipe, all those will save X. But when you put those processes into the doctor's hands, you get X to the power of 10, 20, 100. And so innovation is really putting these mechanics, thought process, and knowledge into the doctor's hands. And doctors are super smart. You give them a small paper and say, Doctor A, B, C, Doctor A, B, and C does this same procedure with this mortality and this cost. Do you want to know more? And he'll quickly call you up later in the evening and say, tell me more. So it's the way you do it, it's the intent to do it, it's the putting the medical thing. But I need just 1 minute for one comment, because I think Dr. Mishra raised a tremendously important point on accidents, trauma, and preventable care. My request to the industry, to the sector, to the government, and for all of us is to jointly collaborate to create through innovation a process, a mechanic, and a framework, so that if a patient sadly has an accident, that he will have access to care quickly. And whether we need to build trauma centers, network, put helicopters, improve our ambulance systems, but also that the doctors, when they receive the patients, are not breaking their head on, can this man afford it? What should I do? It will take us a simple thing to say every automobile insurance. Because all these accidents are 90% happening on the roads, every automobile insurance necessarily you have to pay. And this, every medical bill can be submitted to the insurance companies who are doing automobile. Fine, let us find a system. We need that kind of systemic innovation. So like I said, there's process innovation, there is product innovation, which is happening, and then there's the whole paradigm innovation. And in that paradigm, the first paradigm has to be, life is very precious. Let's do everything we can to protect that life and innovate to ensure. So it's a preventive aspect, from seat belts to helmets to traffic lights to better rules. And then it goes on to say affordability, access, and creating infrastructure. So it is the whole paradigms of life is precious. Because life is precious, what are the innovations we put into place, and how do we ensure a safer country? It's those kind of things at the big level that at conferences like these, we must be collaborating, building the frameworks to enable.
I'll actually take a cue from the collaboration bit you spoke about. And Dr. Mishra, I'll come to you on this. You did raise a very important point, and I think some part of the onus, like you said, lies on these automakers or lies on the industry at large that contributes to the patients who come to you. The question is, though, this innovation in process, in paradigm, in product, has to all be topped with collaboration with government. What kind of a collaboration can the government and the healthcare sector do? I mean, for long we've debated public versus private, but let's talk about the government at large and the industry on one hand.
Government, of course, will give you the direction and give you the problem. It is the industry which has to come with solution of that, for that problem. Now, if you look at, we have never been approached, at least in last 34 years at AIIMS IM, by any industry or any automobile manufacturer, whether it's two-wheeler or four-wheel, doc, what are the problems? Can we solve them? We have not been approached. And that is where India lags behind. Our industry is not willing to put in money in research. It's a very fair and simple statement. People may not like it. How much investment has been made by Abbott in bringing up a, say, new molecule which is used by India and used also by the rest of the world? We all the time complain to USA that it's high cost. They have researched, they have developed, they have discovered. Naturally, they have to recover the cost. For example, recently we had a child coming to the health minister repeatedly for some treatment which was very expensive for the enzyme disorder, you know, where the life expectancy goes down. So he sent this child to me, and then we gave it to pediatrician to give us the idea what this child would require. And that child was requiring treatment which would cost about 2 to 3 crores a year. And my pediatrician told me, sir, we have about 40 such children. Now, USA has done research and discovered that it is some enzyme therapy which works to prevent the progression, and also maybe in some diseases even normal life expectancy can be achieved. But there the mechanism exists that it is provided either by insurance or the kind of endowment which works and they provide through that. But in India we don't have those mechanisms. So either we let whatever is happening to these genetic disorders and these children die, or we develop our own mechanism, and whereby our own pharma industry comes forward and start manufacturing and working towards making these. Of course, this is the rare I am talking about. But then there are commoner things also. For example, helmet. Simple helmet in last 60 years since we are independent, neither our IITs nor our any industry has come out with a simple helmet which women also would like to put, because they also have brains which can get injured when they are driving or sitting on the motorbike.
I'm glad you're acknowledging that at a public forum.
This is the phrase which one of my colleagues in emergency medicine he uses in South. That why women are reluctant to put on helmet when they are sitting as a pillion with their boyfriend, husband, father, brother. Why they are reluctant? Because we have seen at this trauma center in Delhi, if we look at the 100 patients coming with injuries, 90 are men, 10 are women or children or old age. While when it comes to brain injuries, it is 30 women, 70 men. And reason is that all of them are not putting on helmet and fastening it. And they don't, I don't know how much now, LG has just now 2 days ago passed a directive that all women will have to put on helmet, except the sick women are still asking for exemption, which I don't see a reason why they are asking. So I think this is where prevention can work, and innovation in a low cost and light, strong helmet which prevents a head injury, prevents critical care. Because if you look at severe brain injuries, Sangeeta would agree with me, these are the patients require your maximal resources in a hospital, in ICU. Remain there for 1 week to 6 weeks to 6 months to a year. And still you see the outcome of Michael Schumacher. He is not going to go back to his pre-injury state. Never ever it is going to happen to him. Even if we spend whatever. And the family are going bankrupt because of this, because there is no long-term rehab care in India. It is the families who have to take care of these patients at home. He was the breadwinner, now he is dependent for life. So innovations can happen. Innovations can mean to Sangeeta differently, to Mr. Vij differently, to someone differently, but we must try and bring down the cost of healthcare. It is not only in India we are concerned, it is developed countries are also concerned with the cost of care. Obamacare is all about bringing down the cost, and how we can make it affordable to each and every section of society. I say it's a paradox. I am working in a corporate hospital where I cannot get treated myself. What kind of system we have made? We are asking every time, we are saying healthcare tourism, where we are not able to provide healthcare to our own citizens. What health tourism for whom? So these are the things I think we need to work on. Industry has to work on how we can do in next 20 years, 30 years, at least we have to put some timeline on this.
We started with innovation and the debate rightly so veered towards cost, and I think that's the reality that we'll all go back with. Innovation that is going to lead to costs coming down and experiences going up is perhaps what the healthcare sector needs now, topped up with, of course, government intervention. Thanks very much. You've been a fantastic and a very interactive audience. Thanks each one of our panel. I hand it over back to you.